Oh, God.
It's a lot of information, but it's actually kind of repetitive. So we'll hopefully get through it fairly quickly. So we're talking about prostate health today. So we're going to talk about prostatitis, we're going to talk about BPH, and we're going to talk about prostate cancer.
The answer is DRE.
You will see patients with prostate conditions. All right, learning objectives, see the syllabus, because there's a lot of them for these three subjects. All right, so basic prostatic anatomy. Hopefully you saw this in A&P. So it's a gland. It sits just below the bladder. Under normal circumstances, it's about the size of a walnut. Okay? Now, from a textbook perspective, the upper limit of normal for a prostate is between 25 and 30 cc's. Okay? It is possible for someone to have a wildly enlarged prostate and not have any symptoms at all. It is also possible for somebody to have a prostate that is technically within normal limits from a size, from a volume standpoint, and have really bad voiding symptoms. Okay? So the size of the prostate is, well, the size is objective, but the symptoms that they have are subjective. Okay? The prostate, the function of the prostate is part of reproduction. Okay? So the vast majority of the fluid volume in ejaculate comes from the prostate. So when someone has a vasectomy as a method of permanent birth control, the expressed volume of ejaculate basically doesn't change. Only about 1% of the total fluid volume of ejaculate is sperm. The rest of it comes from the prostate and the seminal vesicles, which are behind the prostate. Okay? Prostatic fluid acts as a buffer. It helps keep sperm alive so that they can survive in the female reproductive tract long enough to get to an egg and fertilize it. Okay. And as you can see, it starts growing at birth, and then at puberty, there's a rapid burst of growth, and then the prostate never stops growing because prostatic growth is fueled by testosterone, and men don't go through menopause. Now, at age 40, testosterone levels start to decrease incrementally by about 1 to 2% per year. But as long as there's testosterone production, the prostate's going to continue to grow. The prostate can be divided into several different anatomic zones. The reason that these matter is because the peripheral zone is the site of the majority of carcinomas. Okay? And you can see that the peripheral zone is the zone that's in green here. And the majority of the peripheral zone abuts the rectum, which is why we do prostate biopsies the way that we do. Transrectal, ultrasound-guided needle biopsies. The area of the prostate that's most likely to develop a carcinoma is most easily accessed that way. You can see that some of it is anterior though, and that can be challenging to get to from a transrectal biopsy. You can, but it's challenging. Sometimes we'll do transperineal biopsies to reach that area. That requires a trip to the operating room and sedation. They used to do them in clinic in the old days. I've seen it done that way once. It wasn't pleasant for the patient. Okay. Transition zone surrounds the urethra. That's the area where you're most likely going to see enlargement of prostate tissue, BPH, and that's the area that we end up cutting out when we're doing something like a transurethral resection of the prostate to address obstructive voiding symptoms. Okay. All right, so prostatitis. Multiple different categories of prostatitis. The ones you really need to worry about are acute bacterial, chronic bacterial, and then the rest of them are kind of lumped together. Category 4, asymptomatic inflammatory prostatitis. This is a diagnosis made on tissue biopsy. So it's asymptomatic, right? Patient doesn't have any symptoms, they're not being bothered by it. But on prostate biopsy, they may note inflammation in the prostatic tissue that's sampled. And so unless you have a patient who had a prostate biopsy, you're not gonna see this, you're not gonna diagnose it, so we're not gonna talk about it, okay? All right, so acute bacterial prostatitis. Just like with urinary tract infections, most common organism is E. coli. Often it's an ascending infection. So patient might have a UTI first and then develop prostatitis. It is possible for a patient to develop prostatitis in a vacuum though. So like they don't have a UTI first, they just develop prostatitis. And we talked yesterday about epididymitis, where infected urine can end up getting forced down the ejaculatory ducts. Well, it has to get through the prostate before it gets to the testicles, right? So, same mechanism as far as how the infection gets there, through the ejaculatory ducts. So, you can see here the ejaculatory ducts are right here on this structure called the verumontanum. You can see that on cystoscopy, so if you put a cystoscope in and run up the urethra, there's this structure that bulges out of the posterior wall of the urethra. That's where the ejaculatory ducts open up. That's an important surgical landmark for us because what do you see that's right here just distal to the verumontanum? The sphincter. So when we're doing a resection of the prostate, we don't go distal to the verumontanum, because if we do, we can get into the sphincter muscle and make the patient permanently incontinent. All right, so in acute bacterial prostatitis, the name says it all. It's acute, right? Abrupt onset. Perineal pain, sacral pain, suprapubic pain, fever, chills, malaise. If you see a male with pelvic pain and a fever, have bacterial prostatitis in your differential. Have UTI in your differential too, because again, any male with a UTI is complicated, right? The men aren't supposed to get urinary tract infections, and they may have a fever. Probably gonna have irritative waiting symptoms, and they may also have obstructive symptoms. Chances are they had obstructive symptoms to start with, and now they're developing prostatitis as a result. And with acute bacterial prostatitis, because of the swelling that takes place in the tissue as a result of the infection, they can go into florid urinary retention. Oftentimes they need to have a catheter placed. So, they're gonna have a fever. Their prostate is going to be exquisitely tender to palpation. All right? Rectal exams are inherently uncomfortable to begin with, but somebody with a case of acute bacterial prostatitis, they'll hit the ceiling when you press on their prostate. And you want to do that gently, because if they have acute bacterial prostatitis and you aggressively palpate their prostate, you can actually end up forcing bacteria into the bloodstream and make them bacterial. So you gotta be careful. You do need to do a prostate exam if you suspect somebody has acute bacterial prostatitis to help you confirm the diagnosis, but you want to be gentle with it. Yeah, don't do that. No. Please don't. All right, so laboratory findings, they're gonna have leukocytosis, and you should consider doing blood cultures. Even if they're not hypotensive, tachycardic, consider doing blood cultures. Because if they've got acute bacterial prostatitis, they may already have bacteria in the bloodstream. Okay. Urinalysis with midstream urine culture. Very challenging to get patients to do a midstream collection, even though that's what they're supposed to do. Tell them how to appropriately do a urinalysis when you're giving them the cup. Start urinating in the toilet, then start catching the urine after you've urinated a little bit, and then stop collecting in the cup, finish in the toilet, but they're just gonna pee in the cup. You're gonna see all the things you'd expect to see in somebody with a urinary tract infection, okay? They may have hematuria, they may not. If they're under the age of 35, or they live in a nursing home or retirement community, consider checking them for gonorrhea and chlamydia. And then you don't necessarily have to do imaging. But if you've made a diagnosis of acute bacterial prostatitis and they're not getting better, or they're really sick, like I'm admitting you to the hospital sick, then you may get a pelvic CTC to see if they have an abscess. Abscesses sometimes can be addressed by interventional radiology. If they're large enough, they can actually place a drain in the prostate transperineally. Or we'll take them to the operating room and unroof the abscess, which is an extremely satisfying procedure. You take the roof off a prostate abscess and pus just goes, starts rolling out. It's very satisfying. Not just because, I mean, I don't know how many of you watch Dr. Pimple Popper on YouTube, but you know that you fixed the patient. Like this person's gonna get better now because I've drained this abscess. And prostate abscesses can get really big. I've unroofed prostate abscesses before where the cavity that was left behind after we irrigated out all the dead tissue and purulent material was big enough to drive the scope into. I mean, they get big. All right, so differential, I've said this before, make sure that you can formulate a differential. This is something that trips students up a lot when they get to their clinical rotations. We don't necessarily expect you to come to the correct answer, but you should be in the ballpark, and you should be able to come up with at least 3 items on a differential diagnosis, okay? So pyelo, epididymitis, cystitis, diverticulitis can cause pelvic pain and potentially urinary retention, and pyuria if they have a fistula, right? And then BPH, way down at the bottom, because just BPH, they're not gonna have a fever. Their urine's probably gonna be clean, unless the BPH has caused urinary stasis, in which case their urine's gonna look dirty. But they're not gonna be sick with BPH. How do you treat it? They're gonna be in a lot of pain. So manage their pain. And then this is one of those situations where the first line treatment is a fluoroquinolone. Okay? If they can't tolerate a fluoroquinolone for some reason, like there's a contraindication to it, you're worried about, long QT, or they're allergic, or they've had fluoroquinolones in the past and developed myalgias, then Bactrim. And you're probably going to end up erring on the side of 4 to 6 weeks of treatment. Another reason to be careful with fluoroquinolones, because there is a risk of spontaneous tendon rupture with fluoroquinolones, which is why I say if they've had myalgias in the past on fluoroquinolones, you don't want to give them a fluoroquinolone. I've seen that once, not the tendon rupture, but the myalgias. So it does happen. And then again, consider treating them for gonorrhea and chlamydia. So in that case, you're going to give them Restefin, Doxy, and a fluoroquinolone or Bactrim. Okay. When do you admit them? Well, if they look septic, tachycardic, hypotensive, don't pass the eyeball test, admit them, put them on IV antibiotics. If they just can't tolerate PO intake, well, if they can't keep antibiotics down, then you need to give them something IV until they've recovered enough that you can transition to oral antibiotics. And remember, we talked about this before. Fluoroquinolones have the same bioavailability whether they're PO or IV. So you start them on IV, get them stabilized, then transition them to PO. If they have acute urinary retention, you're going to want to keep them in the hospital at least long enough to make sure that they're able to urinate on their own. And then if you tried outpatient management and they didn't get you better, then admit them. Okay. And again, you see here your inpatient antibiotic regimens. Quinolone plus or minus aminoglycoside. Usually you're talking like Cipro or Levaquin and gentamicin. If they're really, really, really sick, you might even start them on Zosyn as your first line treatment. Jet Zosyn is a great combination because they're synergistic. So if you give somebody gentamicin and Zosyn, the two combined is greater than the sum of their parts. And then after they've been afebrile for 2 days, then you can transition them and make sure that they stay afebrile and then discharge them. If they're in retention, try to place a catheter. Don't force it, make things worse, right? Just like doing an aggressive DRE can make them bacteremic, so can an aggressive attempt at a catheter placement. Don't be afraid to call urology. Sometimes we do end up having to put in a suprapubic tube. In fact, in really severe cases, they describe putting in both a urethral catheter and a suprapubic catheter to maximize drainage. There's some debate as to whether or not having a Foley catheter in impedes the ability of the prostate to drain itself of the nastiness that has accumulated in there. So you don't want to leave the catheter in any longer than you absolutely have to. And then always get a follow-up urine culture to make sure that you've eradicated whatever was growing there, so they don't develop chronic bacterial prostatitis. Questions on this? Okay, chronic bacterial prostatitis usually follows an acute bacterial prostatitis, but it doesn't have to. 50% of affected men with chronic bacterial prostatitis have no known history of an acute infection. E. coli, still the #1 cause, but any of the things that can cause a urinary tract infection can potentially cause chronic bacterial prostatitis. No fever. So they'll have the irritative voiding symptoms, pain, urgency, frequency, dysuria. They may have a history of UTIs, but they're not febrile. And on DRE, they may have a normal feeling prostate. And the only way to really learn what a normal prostate feels like is sets and reps. You just gotta do DREs. And you'll eventually learn, oh, that's normal. And the first time you feel an abnormal prostate, you're gonna go, wow, okay, that wasn't right. But you just gotta do them over and over and over again to learn what normal feels like. So a boggy prostate means it feels kind of mushy. The prostate should be relatively firm, but if it feels, so think of it in terms of like pitting edema. So if you can visualize pitting edema, even if you've never actually felt pitting edema in somebody's legs, think about it that way. It's not gonna pit, you're not gonna push on the prostate and it's gonna leave an indentation, but that kind of mushy sensation is what a boggy prostate is. Okay. Or it may feel swollen. The initial UA is likely to be unremarkable. If it's chronic bacterial prostatitis, the bacteria is in the prostate and nowhere else. So a UA isn't likely to be positive. They can be, but it's not likely to be positive. So textbook answer for how you diagnose chronic bacterial prostatitis is expressed prostatic secretions, which we'll talk about more on another slide. Okay. And then a post-prostatic massage urinalysis. So you express prostatic secretions, culture them separately, and then have the patient do a UA, and that will flush whatever's left in the urethra out with the urine, and then that's what you're culturing. Okay. And then they might have a leukocytosis, but usually they don't. So, express prostatic secretions. Looks pleasant, doesn't it? So you have the patient lean over an exam table, you do a DRE, and the way that prostatic massage is described in the literature is you start lateral and proximal, and then you sort of rake backwards gently and work your way across the prostate from left to right or right to left, whichever side you started on. proximal to distal and work your way across. And that usually causes some prostatic fluid to be expressed, and you have to be ready with the specimen cup to catch whatever drips out, okay? And then after that, then you give them a urine cup and have them do a urinalysis as well, okay? So other things you might do in somebody with chronic bacterial prostatitis. So urodynamics is the catch-all term for all of these various things that you see here. Doing a post-void residual is technically part of urodynamics, but if like on an inpatient ward, if they have a bladder scanner, which is a specialized ultrasound that just measures residual urine volume in the bladder, if you have that done, or if you do it yourself, because on a medical surgical ward, if they have a bladder scanner, the nurses know how to operate it. And so you can ask the nurses to get a PVR with a bladder scanner. Technically, that is part of urodynamics, but if you just do it in a vacuum, it's a PVR, okay? We're not gonna get into the nuts and bolts of urodynamics in this lecture, but it's a functional study of how well the bladder functions and how well the urinary tract empties itself. All right, differential diagnosis, other prostatic conditions, chronic urethritis, cystitis, interstitial cystitis, etc. Any questions about that? How do you treat it? It's generally treated as an outpatient because they're not sick. Same agents as with acute bacterial prostatitis. Tailor your treatment based on culture and sensitivities, and 4 to 6 weeks of therapy. Okay. They shouldn't have systemic signs. If they've got systemic signs, it's probably not chronic bacterial prostatitis anymore. It might have started as chronic bacterial prostatitis. But generally speaking, with chronic bacterial prostatitis, you're not going to admit the patient. And then they may need some anti-inflammatory agents. Hot sitz baths might help. And alpha blockers for any obstructive symptoms that they have, which you should also do in the patients with acute bacterial prostatitis. Forgot to mention that. Especially if they're trending towards going into retention. Anything you can do to relieve outlet obstruction will help prevent that from happening. It's frustrating to treat because it can be difficult to cure. Remember we talked about the poor tissue permeability in the prostate for antibiotics. That's why you have to treat them for 4 to 6 weeks, because it just doesn't, antibiotics just don't diffuse well through the prostate. And it may be recurrent. And even after you've treated the infection and cleared the bacteria, they may progress to non-infectious inflammatory prostatitis, which we're going to talk about next. And then they just have a painful prostate. And that's, again, challenging to manage. So chronic pelvic pain syndrome or non-inflammatory chronic prostatitis. This is like in the same realm as interstitial cystitis in terms of it's frustrating, it's challenging to treat, it makes patients miserable, it makes you miserable because you can't make the patient better. And like it says on the second bullet there, despite the term prostatitis, it's unclear what degree the prostate actually is involved in these symptoms. A lot of times these patients have increased pelvic floor tone, so the muscles of the pelvic floor are tense. You hear people say things like, I carry my tension in my shoulders, right? I'm tense up here all the time. You think about tension headaches and that sort of thing. Think about that in terms of the pelvis. If they're tensed up all the time, then it eventually starts to turn into chronic pain. It's a diagnosis of exclusion, just like interstitial cystitis, because you got to make sure it isn't chronic bacterial prostatitis first or some other pelvic condition that's causing their pain. And then your end result is to say, okay, well, it sounds like you have chronic prostatitis, it's not infectious. AKA chronic pelvic pain syndrome. Okay. No history of UTI. Pain during or after ejaculation is common. And they might also complain of pain in the groin, the testicles, the low back. And like I said, quality of life is greatly decreased. These patients are miserable, and you will be miserable too. So, diagnosis of exclusion, there's nothing that's really pathognomonic, to make a slam dunk diagnosis. But if you do express prostatic secretions, which you should do because you're going to try to rule out chronic bacterial prostatitis, their cultures are going to grow out negative. They're not going to grow out anything. Okay? So, absence of positive cultures is a defining feature. And as we've talked about before, if they've got irritative voiding symptoms and negative cultures, you've got to make sure they don't have bladder cancer, because a bladder tumor can cause irritative voiding symptoms. So for all these patients with prostatitis, you're going to end up referring them to urology, and we're going to take over here. Don't get a cytology. We'll do that. So how do we treat it? Multimodal therapy, because again, it may be the prostate, it may be pelvic musculature. There's a whole lot of different things that can contribute to these chronic pelvic pain type symptoms. We almost always send these patients to behavioral health. They almost always have anxiety and depression. Did they have anxiety and depression before they developed prostatitis, or is the prostatitis causing their anxiety and depression? Could be either. But either way, you need behavioral health to help manage that. We'll often put them on gabapentin, off-label use for amitriptyline for chronic pelvic pain, unless you're actively treating anxiety and depression, then it's on-label, right? But otherwise off-label. Sometimes we'll use neuromodulation, like percutaneous tibial nerve stimulation, or TENS unit. Acupuncture is used. So if you have access to acupuncture, like if you have a pain management clinic, they can be very, very helpful in managing these patients. And then if they have concomitant sexual dysfunction, your PDE5 inhibitors. Prognosis is annoying recurrent symptoms. There is also an over-the-counter, it's technically a dietary supplement as far as the FDA is concerned, but it's actually one that's been well researched. It's called ProstaQ. This isn't going to be on a test anywhere. You can't write a prescription for it. Patients have to buy it themselves, and it's expensive. PROSTA-Q, ProstaQ. It's actually been so well researched that the results of those studies have been published in reputable journals. And I have had patients that I've told about it, they've decided to try it, and a lot of them have had positive results. Okay? I have no financial interest in ProstaQ. So remember, the chronic prostatitis can be inflammatory, it can be non-inflammatory, no history of UTI, no fever, physical exam normal, all labs normal. There's your ProstaQ, right there. Alpha blockers for symptomatic relief of any obstructive symptoms that they might have. And then we'll probably do formal urodynamic testing to make sure they don't have some sort of voiding dysfunction. And again, you won't ever see this personally, because it's going to be diagnosed off of a biopsy. Potentially off of a semen analysis, but if you see a semen analysis that has leukocytes in it, you're not going to jump. That's not a leap that you're going to make. Oh, there's leukocytes on the semen analysis. They have asymptomatic inflammatory prostatitis. really it's diagnosed on biopsy. It's an incidental finding. Questions on that? Okay. Probably a good idea to know this chart to help differentiate between the various types of prostatitis. Acute bacterial fever. No fever, positive culture, chronic prostatitis. No fever, negative culture, chronic pelvic pain syndrome, inflammatory, incidental finding on biopsy, non-inflammatory, asymptomatic. Okay. If they've got a fever, it's acute. Right. So that's prostatitis. You will see it. Chances are some of you in this room will suffer from it at some point in your life. Sorry. All right, so BPH. This is probably the most common urologic complaint in men. Because, as I've already mentioned, the prostate continues to grow until you die. So chances are, at some point, a male is going to have some issues with their prostate. Statistically speaking, 2/3 of men have some issue with their prostate at some point during their life. Whether that means BPH, prostatitis, prostate cancer, 2/3 of men will have to deal with something. Okay. Technically speaking, BPH is a histologic diagnosis. Because the only way to know if they have hyperplasia of their prostatic cells is to look at them under a microscope. But we use the term BPH to describe any patient who has an enlarged prostate on exam and voiding symptoms. Actually, they don't even necessarily have to have voiding symptoms. If they've got an enlarged prostate on exam, most people just use the term BPH, even though technically you can't determine that without tissue. As you can see, it correlates with age. And again, this is using autopsy specimens. So patients who agreed to donate their bodies to science after they died, they looked at their prostates to see if they actually had histologic evidence of BPH. By age 81 to 90, you're approaching 100%. As I mentioned before, transition zone, which is where? Where's the transition zone? Around the urethra. It is technically a benign tumor. Don't tell patients that. Just tell them they got a big prostate. Use the word tumor and patients lose their minds. Don't tell them it's a benign tumor. But it is technically a benign tumor. Why does it happen? Probably multifactorial, but the real key here is dihydrotestosterone. So dihydrotestosterone is created in prostatic cells from regular testosterone. So regular circulating testosterone is taken in by prostatic cells and they convert it to dihydrotestosterone, which they need for their normal function. Which is why you'll see one of the things that we use to treat BPH is 5-alpha reductase inhibitors, which inhibit the conversion of testosterone into dihydrotestosterone. Dihydrotestosterone also plays a role in male pattern baldness, which is why we use 5-alpha reductase inhibitors to treat male pattern baldness. If anybody's ever heard of Propecia, they used to have commercials on television for Propecia. It's the same drug as Proscar, which is what we use to treat BPH, but in a lower dose. So Propecia is 1 milligram per tablet, Proscar is 5. Same drug, different FDA indications, different names, different marketing. Already talked about 5-alpha reductase, converts testosterone to DHT, which causes cellular proliferation. And the cells actually get larger. It's not just there's more cells. The cells that are there get bigger. That's the hyperplasia. Okay? And again, you need tissue to know that that's actually happening. This is a prostate with BPH. I know that you can look at that and go, how does that look different from normal? Well, you can kind of see there's nodules, sort of nodule formation here. It looks sort of thickened around where the urethra is, okay?
Because the way it is.
Usually due to proliferation of cells in the transition zone. But you can have proliferation of cells outside of the transition zone. But it's mostly the transition zone where the problem arises. Okay. Usually this presents with obstructive symptoms if they're going to have symptoms. As I mentioned, you can have a wildly enlarged prostate and not have any symptoms whatsoever. Subjective or objective. You can have patients that don't have any urinary retention that they're not aware of, you know, residual urine that's left behind after they've urinated. You can have patients that have that and don't know it, but you can have patients that have huge prostates and don't have any residual urine left behind. Okay. Obstructive symptoms from literally the patient having to strain to push urine past that enlarged prostate, or they can have irritative symptoms that is the bladder, it's still a result of the obstruction, but the bladder gets irritated. It's angry about having to work so hard, and so they have urgency and frequency. They can also have urgency and frequency if they're not emptying all the way. So if they've got a large residual left behind, the bladder knows that, and it just keeps telling them they need to go to the bathroom, but they're not able to void all the way. They're not able to empty it all out. And so those nerve endings in the bladder just keep firing. Size on DRE correlates poorly with symptoms. Big prostate, no symptoms. Small prostate, lots of symptoms. It can happen either way. So how do you evaluate somebody to see how bad their symptoms are? You give them the IPSS questionnaire. It's very simple. It's on a Likert scale. They answer the questions. You add the numbers up. The higher the number, the more severe their symptoms. Okay? Very, very useful in evaluating BPH. And if you give somebody an IPSS questionnaire, you should document the score in your note from that day. IPSS score equals whatever. You don't have to like write a big long, narrative, just IPSS equals and the score, and that's enough for anybody who knows what an IPSS is to look at it and go, oh, this is really high. This is the IPSS. This is available for free on the AUA website. You can download it, print it, give it to patients. Okay. Incomplete emptying, frequency, intermittency, urgency, weak stream, straining, nocturia are the symptoms that the questionnaire asks about on a scale, and then quality of life due to urinary symptoms. So you'll see patients who score like a 35 and they say that they're delighted. Voiding symptoms are subjective. Nobody ever died from peeing on themselves, and some patients just don't care. If you've got somebody who's retired and they never leave their house, they're homebound either functionally or by choice, they may not care that they have all these problems. I don't care that I get up 5 times a night to go to the bathroom. I don't leave the house. I just sleep all day too. Okay. So, detailed history, exclude other possible causes of LUTS. LUTS is lower urinary tract symptoms. Okay. Urgency, frequency, dysuria, straining to void, post-void dribbling, feelings of incomplete emptying. You want to make sure they don't have any of this other stuff going on before you just say, it's BPH. Okay, what are your obstructive symptoms? Hesitancy, that's difficulty initiating stream. I have a hard time getting started. Decreased force and caliber of stream, doesn't come out as strongly as it used to. Feel like I don't empty all the way. Double voiding. That means I finished going to the bathroom and I think I'm done, but if I stand there for another couple seconds, I've got some more to get out. Straining to urinate, having to push really hard. So don't confuse straining to urinate with hesitancy. Hesitancy just means it takes me a while to get it going. Straining to urine means I have to really bear down and push to continue to keep the urinary stream going throughout the duration of the void. And then post-void dribbling. So I'm done urinating and urine continues to dribble out of the urethra. Irritative symptoms: frequency, urgency, nocturia, and dysuria. And the things that you see with asterisks next to them are your most common presenting symptoms. So hesitancy and decreased force of stream, frequency, urgency, nocturia. If a patient has isolated nocturia, that's their only complaint. I get up a lot at night to go to the bathroom, but they have no daytime voiding symptoms, nothing else, just isolated nocturia. Should BPH be what you're thinking of as the most common or the most likely cause of their symptoms? I'm telling you this because this will save you and your patients some issues and actually get you to a more meaningful diagnosis faster. Isolated nocturia. More often than not, if a patient has isolated nocturia and no other symptoms, you should see if they have OSA. They think that their bladder is waking them up at night to go to the bathroom. What's actually happening is they're having apnea. Their apnea is waking them up, and when they wake up, they go, oh, I must need to go to the bathroom. I cannot tell you the number of times that I've had patients referred for evaluation of BPH. Their only symptom is nocturia. We send them for a sleep study, and they've got horrible OSA. And they get started on CPAP, and guess what? They don't have nocturia anymore because it wasn't nocturia to begin with, right? Isolated nocturia. If they've got anything else, definitely make sure that they don't have BPH or something else going on with their urinary tract. But if it's isolated nocturia, be thinking OSA, okay? Happens a lot. Another thing that can cause isolated nocturia is nocturnal polyuria, which you'll see idiopathically, or you can see it in patients who have poor cardiac or renal function. So if they retain fluid, if you've got a patient who, so as part of your workup when you're saying, well, maybe I need to send this person for a sleep study, ask them if their ankles swell by the end of the day. So if you have somebody who notices when they take their socks off at the end of the day that they've got a really significant indentation, because you might not necessarily find edema on physical exam, but by the end of the day, if they've had a lot of third spacing, once they're supine or prone in bed and gravity is no longer pulling towards their feet, their body starts to mobilize that fluid and it's got to go somewhere, and so they start making more urine at night. All right, DRE is going to be variable because again, they might have a normal prostate on exam. Oh, and how do you determine normal prostate size on DRE? Have you guys learned this in Clin Skills? Okay, so as a rule of thumb, or in this case, rule of finger, if the width of your index finger is about 1 centimeter, if you start on the lateral sulcus of the prostate on rectal exam and count finger breadths from lateral sulcus to lateral sulcus, if it's 2.5 finger breadths, 25 cc's. If it's 4 finger breadths, 40 cc's. That's assuming your fingertip is 1 centimeter across. So measure your fingers and know what your, it's like counting distance on land nav. Know what your stride is, okay? And you can use that to estimate prostate volume. It is not super accurate, but it gives you a ballpark because it doesn't tell you anything about the height of the prostate, right? The prostate can grow up as well as out, but it's a good way to estimate prostate volume.
It's like when your height
Okay.
goes.
And then it should be smooth, symmetric, firm yet elastic, not boggy. There's a sulcus on each side, and there's also an indentation in the center of the prostate. So you should feel, this is a terrible way to visualize it, but think the McDonald's arches. Shallow, hump, shallow, hump, shallow. Okay, that's what a normal prostate should feel like. Okay. If you really want to know the volume of the prostate definitively, you can either do it by transrectal ultrasound or CT or MRI. MRI is better. CT and MRI actually tend to overestimate prostate size because the algorithm that the software uses to calculate the volume isn't perfect. But it is more accurate than using your finger. Okay.
I hope so.
And then look at their abdomen, see if it looks like they have signs of visible bladder distension. It can happen. So you can have somebody who, they urinate, but they don't urinate all the way. They don't actually know that they have any symptoms, but you look at them and they've got like a big bulge right here. Ooh, let's put a bladder scanner on that. And they've got huge residual urine. All right, urinalysis and culture, like everything we do in nephrology and urology. Check a function panel, see if they've got signs of obstructive uropathy. And then PSA we're going to talk about a little bit later on. You don't necessarily have to do a PSA as part of workup for BPH. If they're in retention, you probably shouldn't, because retention can cause an artificial elevation in PSA, and then you start going down the prostate cancer rabbit hole. We'll talk more about PSA. And then if they have a high IPSS score, you may end up referring them to us, and then these are things that, well, urodynamics for sure, what we're gonna do. But you have the ability to do a post-void residual yourself, either via a bladder scanner, or you can do invasive post-void residual by doing a straight cath. So you have them urinate till they think they're done, and then you do an in and out cath and see if they have residual urine. Imaging by itself doesn't have a role in the diagnosis of BPH unless they've got other things going on. If they have other signs of urinary tract disease, if they have hematuria, then you're going down the hematuria workup algorithm, make sure they don't have bladder cancer. If they've got a UTI, but just diagnosing somebody with BPH does not require imaging. Okay, it's a clinical diagnosis. Here's your differential. Obstructive symptoms, strictures can cause that too. Bladder neck contracture, this is something you're only likely to see in somebody who has a history of urinary tract instrumentation of some sort, prior urinary tract surgery. Okay, if somebody has had their prostate removed for prostate cancer, can they have BPH? No, but can they have a bladder neck contracture? Yes. This is one of the reasons why it's important to elicit a surgical history. Old guy, obstructive voiding symptoms. Oh, you probably have BPH. I don't have a prostate. Oh, okay. Prostate cancer should be on the differential. You should be thinking about that in an older guy with obstructive voiding symptoms or irritative voiding symptoms. UTI, bladder cancer, neurogenic bladder. Do you have to have a spinal cord injury to have neurogenic bladder?
No.
No. What's the most common cause of neurogenic bladder? What's the most common cause of all of our health problems in the United States? Diabetes. Nerve damage from uncontrolled blood sugars. Just like you can get peripheral problems, paresthesias, you can have problems with nerve function in the bladder. Here's your treatment algorithm. I'll let you peruse that at your leisure. And then treatment options. So if their score is low and they're not bothered, you don't necessarily have to do anything. If their score is high and they're not bothered, you don't necessarily have to do anything. That's why it asks that question at the bottom of the questionnaire: how do you feel about your urinary health? If they're delighted, if it ain't broke, don't fix it. Okay? If their symptoms are severe and they're bothered, again, you can just watch. You don't necessarily have to do anything. Or you can do medical therapy or surgical therapy. And we will talk about those after a 10-minute break. On any exam from me, I can't speak to the other instructors, but on any exam from me, if I ask you to say what is the definitive management for a condition, that doesn't necessarily mean that it's something that you as PAs will do. Definitive management means the end result for the patient. So, to use an example that I was talking about over the break, if you have a stem to a question that says you have a 18-year-old male patient comes into the emergency department with acute onset left testicular pain, on physical exam, you note that the patient's testicle has an abnormal lateral lie and they have a negative Pren sign, and I ask you what the next step is in that patient. With that information, based on what we talked about yesterday, what is the next step for that patient? Ultrasound is the next step. Okay, now, same stem. What is the definitive management for this patient? Bilateral orchidopexy. Do you do bilateral orchidopexies? No. So, a question, or part of the conversation during the break was, isn't that useless information for us? That's not how it was put to me. I'm summarizing, okay? I'm summarizing. Those are my words, okay? The answer is no, and here's why it's not useless information. Patients are going to ask you questions. Patients need expectation management. Patients are going to say, what's going to happen to me? You have to be able to have some idea of what that next step is. Another way to look at it is, if you don't know why you're sending a patient to a specialist, you have a problem. Why am I sending this patient to this person? If you don't have some idea of what you're sending them for, you're just flapping in the breeze. The reason you send a patient with torsion to a urologist is for definitive management via surgery. And it's probably helpful to know that we're going to be operating on both sides. Okay? But you should also never be afraid to tell a patient, I have reached the limit of my expertise. You're going to have to address those questions to the specialist that I'm sending you to. Okay? You might come out of phase 1 not remembering the term bilateral orchidopexy, but you know they need surgery. And so you can say, I'm sending you to a surgeon because you need surgery. What are they going to do? I don't know. I'm not a surgeon. That is outside the area of my expertise. I know you need surgery, but for the details of what's going to be done, you're going to have to ask the specialist. Okay? Do I send patients to oncology for chemotherapy? Yes. Do I know anything about the details of chemotherapy? A little bit. I know enough to say these are agents that they might use to treat you. I don't know what they're going to pick. I am not up to date on the most recent literature on the most effective treatment regimens for this particular malignancy. That's why I'm sending you to a specialist. You will have to address those questions to the oncologist. Okay? Don't be afraid to say, I don't know. The worst thing you can do is try to make up an answer. I think it might be this. Don't do that. Now patients will latch onto that And they're gonna have a preconceived notion that that's what they should expect to hear from a specialist when they get there. If you don't know, say I don't know. Don't make it up. Make sense? Okay, so we were talking about treatment for BPH. Watchful waiting, you just come back when you're bothered. When you stop being delighted, come back, and we'll talk about other treatment options. Okay? Things that patients can do from a behavior modification standpoint is things like we've talked about before with other conditions. So decreased fluid intake before travel and bedtime. If nocturia is an issue for them, again, we're not talking about isolated nocturia here, but if they have nocturia as part of the spectrum of their conditions, tell them that they need to stop taking in fluid about 3 hours before bedtime. Whatever their bedtime is, for 3 hours before bed, don't drink anything. Now, if you have evening meds that you take, wash them down with as little amount of water as is necessary to get your pills to your stomach. Don't drink a whole bottle of water to get your evening meds down, okay? If you can avoid diuretics, do. Oftentimes these patients have multiple medical comorbidities and they're on a diuretic for some other reason and you can't do anything about that. Caffeine and alcohol intake. Caffeine makes you feel like you need to go. So if they already have irritative voiding symptoms at baseline, taking in caffeine is going to make those worse. Alcohol makes you make more urine, right? Because alcohol inhibits antidiuretic hormone. Increased physical activity and weight loss is like the correct answer for everything in medicine. It applies here too. Kegel exercises are helpful as long as they don't have irritative voiding symptoms. If they have irritative voiding symptoms, Kegels can actually make their symptoms worse. You would never recommend that somebody who has chronic non-inflammatory prostatitis to do Kegels. You're just gonna make them worse. Okay? And then timed waiting regimens. So think about the diabetic patient. They've already got paresthesias in their extremities. They may not have a normal sensation of bladder filling. They may not have full-blown neurogenic bladder yet, but they may not have a normal sensation of bladder filling. And so telling them to void on a schedule, even if they don't feel like they need to go, can be very helpful in managing their symptoms. All right, pharmacotherapy. So your first generation alpha blockers, we talked about this with stone disease. So these have very broad effect on alpha receptors. Terazosin was originally discovered as a blood pressure medicine, and we don't use it for that anymore because of tachyphylaxis. It does work very well for BPH symptoms that are obstructive in nature, but it also has an effect on patients' blood pressure until they've been on it for a little while. So if you have concerns about a patient having orthostasis and falling over and hitting their head when they get up in the morning, don't give them these unless you have no other choices. Like if you're working, in a medical mission, in Honduras or something like that, or if you're volunteering in an indigent clinic and this is what they have available, then that's what they have available. But you got to caution patients about orthostasis. So any of these medications should be taken at bedtime so that transient orthostasis happens while they're asleep. And you need to caution them that when they get out of bed, they need to not just jump out of bed. Sit up, sit there for a second, swing your legs over, sit there for a second. Stand up, but don't move away from the bed, stay there for a second, make sure you don't get lightheaded or dizzy, and then carry on. Okay. After they've been on medication for a couple of weeks, they will develop tachyphylaxis from a blood pressure standpoint, and then you don't have to worry about that orthostasis as much. Okay. These medications also cause retrograde ejaculation. So something you need to tell patients about. If you don't caution them about that up front, they might be very upset with you. So retrograde ejaculation, all that means is that when they have an orgasm, their ejaculate goes backwards into the bladder rather than coming out the urethra. Because when you relax the smooth muscle fibers in the prostate and the bladder neck with an alpha blocker, the backstop of the closed bladder neck is no longer there. So the path of least resistance for ejaculate now becomes retrograde. It doesn't happen to everybody, but it's something you need to tell patients about so that they don't lose their minds over it. Everything feels normal, just nothing comes out, or very little comes out. Okay. These medications have lower side effects. They're once a day, they're time-released formulations. Any of them is an appropriate choice. Flomax, I think, is the one that's still on the DoD formulary. So you don't have to get any sort of prior authorization to write for Flomax. 0.4 milligrams daily, QHS. That won't be on the test, like dosing, but that's a good one. Okay. All right, so why is it a problem? We've talked about that. How do alpha blockers work? It relaxes the smooth muscle fibers within the prostatic stroma in the capsule and reduces outlet obstruction. 5-alpha reductase inhibitors. So if somebody has a normal prostate volume, putting somebody on a 5-alpha reductase inhibitor is probably not going to be helpful. Okay, so they need to at least have an enlarged prostate before you put them on a 5-alpha reductase inhibitor. 5-alpha reductase inhibitors don't work overnight. They take time. Rome wasn't built in a day. The patient's prostate didn't get as big as it is in a day. And 5-alpha reductase inhibitors work by shrinking the prostate. So if you starve the prostate of its source of dihydrotestosterone by inhibiting its ability to make dihydrotestosterone, it starts to get smaller. Does it work for everybody? No, not everybody's prostate shrinks, but you will arrest the growth, even if it doesn't shrink. So if the patient has a large prostate, you've documented a large prostate, either on DRE or with imaging, then a 5-alpha reductase inhibitor might be a good first choice. Oftentimes, we'll do combination therapy. We'll start them on a 5-alpha reductase inhibitor and an alpha blocker, both. Okay. 5-alpha reductase inhibitors have an effect on PSA, which we'll talk about here in a second, that you need to keep in mind, something you need to track. Finasteride is Proscar. It's the oldest one. It's been around for a very long time. It's well studied. It works very well. Dutasteride is Avodart. It's the new kid on the block. There are 2 different isomers of 5-alpha reductase. Finasteride only affects one of them. Dutasteride affects both. The theory is that it should work better because it's affecting both isomers, but the jury's still out on whether or not that's actually true in vivo. Okay. So PSA is reduced by 50% when somebody is on a 5-alpha reductase inhibitor because PSA is made in the prostate, and again, it's dihydrotestosterone that fuels that production. So if you cut their dihydrotestosterone production, it's going to reduce their PSA. Does reducing the volume of detectable PSA in the bloodstream reduce a person's risk of prostate cancer? The answer is it probably does, but the end result for you is whatever you do with, as far as PSA screening, whatever number you get back on somebody who's on one of these medications, you need to double it in your head. Okay, so if you have somebody who's on finasteride or dutasteride, you check their PSA and it's a 2, functionally it's a 4. Okay, now this won't be on the test, but it's something you're likely to hear about. Finasteride has a black box warning on it that says may cause prostate cancer. Do you think there is a urologist on earth that would prescribe a medication to a patient that might cause prostate cancer?
Yes.
No. We don't think that's true. The FDA put it on the box, and here's why. When they did the research on finasteride, when they did the phase 1, 2, 3 clinical trials, what they found was patients in the finasteride arm had a significantly decreased risk of prostate cancer overall compared to the control group. So the control group had more prostate cancer. The finasteride group had less prostate cancer. However, if the finasteride group, if patients in the finasteride group developed prostate cancer, it was usually of a higher grade. The conclusion that the researchers made was finasteride prevents low-grade prostate cancer. The overall incidence is lower. When they do get prostate cancer, it's of a higher grade, meaning that high-grade prostate cancer just blew through it. It blew through the finasteride effect. But the FDA looked at that and said, no, it causes prostate cancer. So there's a black box warning on these meds. Something you need to tell patients about when you start them on them, okay? And you can counsel them the exact same way that I just said. Do you think I would start you on a medication that I think causes prostate cancer? No, and then you can tell them the story. Finasteride, the researchers actually tried to get an FDA indication for prostate cancer chemoprophylaxis because the results were so compelling that it prevented low-grade prostate cancer, and the FDA went, nah, it causes prostate cancer. Not kidding. The lead researcher on that study was one of my instructors in residency. He was the chair of urology ET. Okay, so combination therapy, we talked about alpha blockers and a 5-alpha reductase inhibitor. Sum is greater than its parts. The alpha blocker helps with immediate relief of symptoms, and the 5-alpha reductase inhibitor helps improve things over time as the prostate shrinks. Okay. Can you use a phosphodiesterase 5 inhibitor to treat BPH symptoms? Yes, there is an FDA indication for the treatment of BPH with Cialis or tadalafil, daily, low dose. Okay? Is that easy to get from a DoD pharmacy? No. It requires prior authorization, and they have to have failed other things first. Okay? The interesting thing to note about this is that, okay, so think your IPSS score, right? It's very subjective. Patients are answering it based on their perspective of how their symptoms have improved. And then they have that question at the bottom about, I'm delighted or I'm miserable, right? If you actually objectively measure a patient's voiding parameters, the strength of stream, how much they get out in 30 seconds, whether they have a post-void residual, and if so, how much. If you measure those things on an alpha blocker or a 5-alpha reductase inhibitor, those numbers actually improve. They get better. The strength of stream gets stronger. They empty better. Tadalafil, their voiding parameters don't change at all. Objectively measured voiding parameters don't change at all. But their satisfaction with their urinary health goes up. Now, is it because they're voiding better? Or is it because they're having spontaneous erections that aren't really spontaneous because they're taking an ED medication daily? Doesn't matter. It has an FDA indication for BPH symptoms because subjectively they get better. And finasteride causes prostate cancer. Don't you love the FDA? Okay, so the reason we can use tadalafil daily for BPH symptoms and for ED is because of its half-life. So the half-life of tadalafil is like 36 hours. And so if you take a 20 milligram dose, that means that you don't have to worry about taking medication 15 minutes to an hour before desired sexual intercourse. The half-life is 36 hours, it's already there, it's already working. If you take 5 milligrams daily, because the half-life is so long, eventually they build up to a steady state in their bloodstream, a steady state concentration that's the same as if they were taking 20 milligrams for on-demand use. And we'll talk more about that in ED's lecture. Okay, surgical indications. If they have recurrent UTIs, if they're in retention and it doesn't go away with pharmacotherapy, if they have persistent gross hematuria that is a result of their BPH, so as the prostate enlarges, they can develop prostatic varices in the urethra, and just the turbulence of urine going by can be enough to make those rupture and bleed. If they have bladder stones, if they have chronic renal insufficiency that is believed to be post-renal, obstructive in nature, then those are reasons for surgery. Large bladder diverticula, once a patient has trabeculations and diverticula in the bladder from voiding against an obstruction for an extended period of time, you can't make those go away. Once they're there, they're there. The bladder remodeling doesn't reverse itself. So that's a relative indication. All right, so how do we do it? Minimally invasive therapy, transurethral resection of the prostate. I'm not gonna belabor a lot of this, because again, do you need to know about it? Yes. Do you need to know how to do it? No, not really. But basically you go in with a scope and you core out the prostate like an apple using electrocautery or a laser. There's multiple different ways to skin the cat. Spinal anesthesia is preferred because on the older technology for doing this, you had to use sterile water as the irrigant, and that sterile water would get into the bloodstream through the vessels that you were unroofing while doing the resection, and it would cause the patient to become hyponatremic. And the way that you could monitor them was by making sure that they were still neurologically with it. Well, how are you going to make sure somebody's neurologically with it if they're under a general anesthetic? You can't. So spinal anesthesia, the anesthesiologist during surgery can tap them on the head and say, what day is it? Who's the president? What's your address? And if they start answering questions wonky, then you start worrying that maybe that you've caused an electrolyte imbalance. It's called TUR syndrome, to cause hyponatremia via surgical resection with a hypotonic fluid. Okay? So, bottom right diagram, you see these corn puffs on the enlarged prostate nodules. Start carving them out, and in the end, you end up with this big, wide open prostate fossa.
That's where my corn puffs were.
No more obstructive tissue. Green light laser TURP, as I mentioned, there's multiple ways to skin the cat. With a green light laser, you're actually vaporizing the prostate tissue. The downside to that is you don't have tissue to look at under a microscope and make sure they don't have occult prostate cancer that they didn't know about. You can electrovaporize the prostate. Transurethral incision of the prostate is specifically for patients with tall prostates. So if they have a big, tall prostate, they might have a relatively wide open urethra on cystoscopy, but because they have a big, tall prostate, it impinges on their ability to empty their bladder, and so what you do is you just make an incision in the prostate from the bladder neck on either side of the posterior urethra down to the verumontanum, and it causes the prostate to fall open and downward, and it relieves their outlet obstruction. And then Urolift is something that can actually be done in clinic under local anesthetic. You're basically using suture anchors that are deployed through the cystoscope to tack the walls of the prostate back. So you don't remove any tissue. You're just pushing it out of the way. And those are permanent anchors. Water vapor thermal therapy, robotic water jet. So you can vaporize tissue with high temperature water vapor, or you can ablate it, think like sandblaster without the sand, right? You're blowing the tissue out of the way with high pressure water. Okay? I'm not gonna have any questions on the test that asks you to differentiate between these treatment modalities. Just know that they exist. Laser enucleation, this is different from vaporization. You use a laser to actually carve your way around the adenoma and then pull the adenoma out in block. The advantage of that is that you now have tissue that you can send to the pathologist and have them look at under the microscope, and it works very well. It's the same end result as a traditional TURP, just using a laser. All right, open simple prostatectomy. If their prostate is too big to do a transurethral resection. So again, we used to worry about TUR syndrome, so you couldn't resect for more than an hour if you were using a hypotonic solution. Newer modalities allow you to use saline as your irrigant, and you can theoretically resect until the cows come home. You do have to worry about potentially fluid overload from the irrigant getting into their bloodstream, but you don't have to worry about hyponatremia. You do have to worry about the patient being up in stirrups, because you have to put them in stirrups to do the procedure, and so you worry about neuropraxia, blood clots, things like that from the patients being in an awkward position and up in stirrups. So instead of doing a TUR, which you might have to do in stages, bring them back multiple times, you can do an open, simple prostatectomy, which is not the same as prostate cancer surgery. Cancer surgery is a radical prostatectomy. You're taking everything. In an open, simple, you're just taking the overgrown adenoma. This is one I actually did. This is one of my surgical specimens. You can see from the ruler, this is a significantly larger than normal prostate. And that's just the adenoma. Didn't take out the whole gland. So their whole prostate gland was actually larger than this. Okay. Questions about BPH? The key things for you all is, how do I diagnose it? What's on my differential? And then how do I treat it with behavior modification and pharmacotherapy? Those are the things you really need to know about BPH. And then know when to send the patient to a specialist. Okay. All right, the last thing we're going to talk about is prostate cancer. Are you going to manage prostate cancer?
No.
No. Do you need to know how to identify patients that are at risk and send them to a urologist so they can be diagnosed and managed definitively?
Yes.
Yes. Okay. So, prostate cancer is the most common non-cutaneous cancer in men in the United States, and the second leading cause of cancer-related death. It doesn't need to be, but it is. Screening goes a long way towards preventing this outcome, second leading cause of cancer-related death. People just don't get checked. Okay. Or they don't know that they need to be checked. Risk factors. The number one risk factor is age. So remember that graph I showed you earlier on BPH that showed the incidence of BPH based on age? Same study, in addition to looking for BPH, they also looked for occult prostate cancer. So the patients had to not have a known diagnosis of prostate cancer. If they knew they had prostate cancer, then their specimens were excluded from the study. They were looking for the incidence of unknown prostate cancer. But just remember that graph. By age 81 to 90, it was approaching 100%. If you live that long, chances are you've got some prostate cancer. It may not be clinically significant, but it's there. Okay? Which is why we are becoming less aggressive about treating low-grade prostate cancer, because we know by the time you hit, if you become a centenarian, you probably have prostate cancer, as long as you have a prostate. People of African heritage. We don't know why. It has to be something genetic, but they haven't figured out what it is. It's probably multifactorial. Like it's probably like a multi-hit type model, as opposed to it being like a single gene defect. But we know that men of African descent are at increased risk of developing prostate cancer, both earlier and of a higher grade. So it's very, very, very important that men of African heritage get screened earlier, and that if they're found to have prostate cancer, that they're treated a little bit more aggressively, because the likelihood that they're going to develop a clinically significant prostate cancer is high. And we've known that for a long time. If you go back and look at various public service announcements that have been developed over the years to try to increase the amount of screening in that specific population, they go back a long way. Louis Gossett Jr., the actor who was in the Iron Eagle movies and Officer and Gentleman, he was an early spokesperson for prostate cancer screening. Family history, it has to be a primary male relative. Brother, father, okay? True hereditary prostate cancer is rare. Can you have somebody whose family, where a great-grandfather had prostate cancer, grandfather had prostate cancer, dad had prostate cancer, now I have prostate cancer? Yes, you can, but that's rare. But if somebody has a primary male relative with prostate cancer, they are at increased risk. They fall into the high-risk category. So individuals of African descent are automatically high risk. Patients with a primary family history, high risk. why would high fat intake and obesity be a risk factor for prostate cancer?
Adipose tissue, increased hormones.
What enzyme is present in adipose tissue?
Lipid?
There's several. This is sort of a guess what I'm thinking.
Many.
Aromatase. What does aromatase do?
Gets converted into sex hormones.
It has an effect on sex hormones. So what does aromatase do to testosterone?
Increases it.
Turns it to estrogen.
Oh, yeah, sure.
So obese males have higher circulating levels of estrogen, which is also why they develop gynecomastia. And the prostate is not supposed to be bathed in estrogen. It increases risk of prostate cancer. And then toxic exposures. The real big one here is Agent Orange. Okay, smoking might increase risk of prostate cancer. It's not like a slam dunk association like it is with bladder cancer, but Agent Orange is such a strong, has such a strong correlation with prostate cancer that anyone who served on active duty during the Vietnam era, they didn't even have to have been in country, because Agent Orange was so pervasive during the Vietnam era because they stored it on US military bases, they transported it on US military aircraft and on ships. If you served on active duty during the Vietnam era, which is like 1955 to 1975, and you develop prostate cancer, automatic service connection. No questions asked.
That never happens.
That's how strong the correlation is. It's usually asymptomatic, which is why it's hard to screen for, which is why we use PSA, which we'll talk about a little bit more in a second. If they have symptoms, they may have locally advanced or metastatic disease. What are those symptoms? BPH-like symptoms, which is why you have to have that on your differential when you're evaluating somebody for BPH. Okay. For you, the most critical thing is physical exam, DRE, and then PSA to help you detect those lesions that are not palpable on exam. Okay. But on DRE, if you feel asymmetry in the prostate, remember we talked about lateral sulcus, central sulcus, lateral sulcus, like the golden arches. If one side is significantly larger than the other, you have to go further up the hump to get to the medial sulcus than you do on the other side. If you feel a hard spot, a nodule, if the prostate is not springy, if it feels like it's hard as a rock, these are all very concerning findings for prostate cancer, and you should refer them to urology. Okay? And again, you can't palpate the entire gland, but the majority of cancers arise from the peripheral zone, which you can palpate, so that's very helpful. Standard labs to include calcium and alk phos. If they have bony mets already, then they're going to have hypercalcemia and their alkaline phosphatase is going to be elevated. That's only an advanced disease. And then PSA. PSA is extremely controversial. It's extremely controversial. The urologic community says that PSA screening improves outcomes. The United States Preventative Health Task Force says it doesn't. Urology is going to die on that hill. The data that the Preventative Health Task Force looked at was flawed. They didn't look at the whole picture. Prostate cancer is a slow-growing cancer, unless it's extremely aggressive, like it's a high Gleason grade, which we'll talk about in a second. Otherwise, it's a slow-growing indolent cancer, which means you have to follow patients for 15 to 20 years to know what their ultimate outcome is, and if you follow them that long, patients that receive PSA screening actually have a survival benefit. The time frame that the Preventative Health Task Force looked at was not that long. So they said there was no survival benefit, it just makes patients anxious, don't use it. The other problem with PSA is it's not very sensitive or specific. Lots of things can cause elevation in PSA. So just because you see somebody with an elevated PSA, unless it's like 300, if their PSA is 300, they got prostate cancer and it's metastatic. But if you see somebody who has an elevated PSA, it's not a reason to freak out. Lots of things can cause elevation in PSA. Urinary tract infections, prostatitis, acute urinary retention, recent instrumentation of the urinary tract, an aggressive DRE. All of these things can cause elevations in PSA. So you have to follow PSA in trend for it to be useful. Okay? And the size of the prostate. The bigger your prostate, the more PSA it makes. So is a 90-year-old going to have a higher PSA than a 40-year-old? If you had a PSA that you drew on a 40-year-old patient and followed him until he was 90 and checked his PSA at 90, is it going to be higher than it was when he was 40? Yes. All true. So this is sort of an age stratified normal, but what you really need to think in your own head is that there's no such thing as a normal PSA. Okay? Just think about it that way. There's no such thing as normal. Because you can have a theoretically normal PSA and have prostate cancer. You can have an elevated PSA and not have prostate cancer. So it has to be followed in trend. A single, you guys heard this in your radiology block, one view is no view. Did you hear that? Talked about chest x-rays, one view is no view. One PSA is no PSA. You have to follow it in trend for it to be useful. Highly recommend that you look at this risk calculator. It's online. It has you plug in various information about the patient, including their age and their PSA, and it helps you determine what the likelihood is that they have an occult prostate cancer that needs to be biopsied. Very, very handy. Gives you something objective to show patients. Okay. Treatment decisions cannot be made on the basis of PSA alone. That's very important. Just because somebody has an elevated PSA. But if it is elevated, send them to us. We'll take them off your hands. We'll figure it out. Okay. Better if you check more than one PSA before you send them to us, because again, you could have somebody who has an elevated PSA for some other spurious reason. But if you check two PSAs, like separated by say 3 months, waiting 3 months is not going to affect their outcomes. And if it's still elevated after 3 months, the likelihood that whatever was present that was a confounding factor should be gone, will be gone. And if it's not, and the PSA is still elevated, or if it's gone up even further, send them to us. Okay. MRI is gaining traction as a much more first-line evaluation tool for prostate cancer. When I started my training, it was transrectal ultrasound guided biopsy. There was no imaging that you did to help evaluate for prostate cancer. But now you can do multiplanar MRI. You have to have an MRI scanner that's above a certain strength in Tesla. In case you guys didn't know that, MRI strength is measured in Tesla. So you need a 3 Tesla MRI minimum to do really effective prostate MRI. And y'all heard about the BI-RAD system for prostate, or excuse me, for breast imaging, for mammograms? Did you learn about that in radiology? The BI-RADS grading system? So the BI-RAD system is a way for radiologists to tell other clinicians if they see a mass on mammography, the likelihood that it's bad. So a low score is good, a high score is bad. They adapted the grading scale for prostate imaging and called it PI-RADS. So there's a PI-RADS grading system now for prostate MRI. PI-RADS 5, bad. PI-RADS 1, benign. Okay. There won't be any questions about the PI-RADS grading system on a test, just something for you to know. Okay. 20% of patients undergoing radical prostatectomy have a normal, quote, normal PSA. Okay. If they have an abnormal exam, send them to us, regardless of what their PSA is. Send them to us. If you do a DRE and you're like, that's not right, send them to us. We will not fault you. Okay, so this is a transrectal ultrasound probe. This is a transrectal spring-loaded biopsy needle. Okay. This is how we do it. Could you at some point in your career learn how to do this? Yes. The PA that works in the urology clinic at BAMC does prostate biopsies, he does vasectomies. He learned how to do it on the job. There's no fellowship for urology PA. You have to start working in a urology clinic and tell the physicians that you work with that you want to learn these additional skills. And they can teach you and you can operate under their license as far as those invasive procedures are concerned, okay? But not something that you're gonna do as a primary care PA or an EM PA or ortho PA. But we put an ultrasound probe in the rectum, we visualize the prostate, we inject local anesthetic around it, we take cores from the peripheral zone, send them to pathology and let the pathologist tell us what they see. Here's your MRI, talked about that already. We can also use the MRI to help guide the biopsy. So ideally we'll do an MRI before biopsy and see if there's anything that shows up as being a concerning lesion, PIRADS 3, 4, 5. And then we can actually there's software that allows you to fuse the MR images with ultrasound in real time. So the MR images are from a prior study, and they fuse them to your ultrasound in real time. So as you move the ultrasound probe inside the patient, the MR image changes with you and it helps you aim so you know you're aiming at exactly the right spot. Because a lesion that shows up on MRI as being concerning won't necessarily look different from a tissue density standpoint on ultrasound. So it's been a game changer. It's very, very useful. So you can see here, there's an abnormal area right here. I know it doesn't project very well, really, very poorly on that side. But right here, there's an abnormal area, and that means you can target that with a biopsy because you know that it's there. And it wouldn't necessarily have looked abnormal on ultrasound alone. Okay. Staging. I'm going to talk to you in detail about staging the grading system because this is something that you're likely to get questions about in a primary care setting from patients, okay? The Gleason grading system is how we grade prostate cancer. Gleason was a pathologist at the VA, believe it or not, and he created the grading system like so many of these other grading systems we've talked about before, like the Bosniak system for renal cysts. He didn't intend it to be a prognostic tool. It was just a way for him to very succinctly explain to a urologist how bad was the tissue he was seeing under the microscope. Low Gleason score good, high Gleason score bad, okay? And instead of using a lot of pathology terms like extensive mitotic bodies and things of that nature that non-pathologists don't understand, he said, okay, well I'm gonna assign a number based on how bad it looks. And the lowest Gleason score you can get is a 2 because the Gleason score is additive. The first number in a Gleason score is the predominant tissue pattern seen. The second number in the Gleason score is the most significant tissue pattern seen. So if all a person has in the entire tissue specimen is a Gleason grade 3, what is their score?
4?
6. I heard somebody say it. 3, predominant. 3, worst. Because that's what it is. There's nothing worse. They didn't see anything more severe. So it's 3 plus 3 equals 6. Okay? So with that knowledge, if I tell you that somebody has a Gleason score of 3 plus 4 equals 7, is that the same as 4 plus 3 equals 7?
No.
No. So if the higher number is first, that means that is the predominant tissue type seen. It makes up the majority of the core. And then if they saw a secondary focus of 3 that was not the majority of the core, that becomes the second number. So 4 plus 3 is worse than 3 plus 4. Okay? So here's kind of what it looks like. Obviously it's not green to red on, under the microscope. But small, uniform, still relatively differentiated cells. Look a little bit abnormal, but you can still, like if somebody showed you the slide in a vacuum and you were a pathologist, you could go, oh, that's prostate tissue. Contrast that with Gleason grade 5. If you looked at that in a vacuum not knowing what it was, you'd go, I don't know. No idea. Poorly differentiated, anaplastic. Okay? So 5 plus 5 equals 10 is the worst Gleason score. We are getting away, as I mentioned earlier, from aggressively treating people with low Gleason score cancer. There's actually some researchers out there that think that low Gleason score tissue isn't actually prostate cancer. Okay? Jury's still out on that, but I will tell you this, if it's a 7 or greater, it probably needs to be treated. Well, if it's an 8, 9, or 10, it definitely needs to be treated, because if you don't, they're gonna get metastatic prostate cancer and they're gonna die. But a Gleason grade 6, you can probably observe, at least for a period of time. You can do what's called active surveillance. You will
To 5
generally
plus 1.
nowadays not see anything less than a 6 called on a pathology specimen. I can't remember the last time I saw a Gleason grade 5 or a Gleason grade 4 as the final score. 2 plus 2 equals 4. 2 plus 3 equals 5. I can't remember the last time I saw that on a pathology report. It's been a couple decades. So, here's your staging. Less aggressive, slow growing, very low risk. Highly aggressive, rapidly growing, high risk. So there's your risk assessment matrix. We are doing more active surveillance for low-grade disease now. Active surveillance is not the same as watchful waiting. We used the term watchful waiting when we were talking about BPH earlier. They used to use the term watchful waiting in prostate cancer, and it meant the same thing as it did for BPH. Come back when you got a problem. Not a great way to send somebody on their way with a cancer diagnosis, is it? Come back when you got a problem. But that was really what watchful waiting was. Active surveillance is an active regimen. So PSA is checked on a regular basis. Periodic screening biopsies done on a regular basis to make sure that their cancer grade doesn't go up. If it does, they need treatment. If it doesn't, you can continue to watch them. And then, how do we treat prostate cancer? Active surveillance is technically a treatment option, even though you're not doing anything, you're just watching them. And then focal therapy, the ones that are in italics here, we don't do in the United States. They're not FDA approved, but they're done in other places in the world. So something to know about, but because they may be the coming thing, we may start seeing them used here in the United States, but right now we don't. So high intensity focused ultrasound, you're literally like ultrasounding the tissue to death. Cryotherapy. The problem with these targeted therapies is before prostate MRI, you didn't really have a good way to say, well, this is where the abnormal tissue is. We can see it, we can localize it, we can target that localized area. As that technology continues to improve, we may see these focal therapies come more into vogue and get FDA approval in the United States. Brachytherapy is only kind of a focal therapy. So brachytherapy is radioactive seeds. So if you've heard about radioactive seed placement, that's what brachytherapy is. So little tiny seeds of, most commonly it's iodine-131, are placed in the prostate in a templated pattern that is pre-planned by the radiation oncologist so that the seeds create a cloud of radiation that is localized to the prostate gland, capsule to capsule in every direction. So it is localized because you're only irradiating the prostate, and you don't have to worry about radiating external tissues by using external beam radiation. That's why we're calling brachytherapy a localized therapy, but it's still the whole gland. The whole gland gets irradiated in brachytherapy. And then you can do whole gland radiation in terms of external beam radiation therapy, which might be done using a standard linear accelerator, or you can use proton therapy. The brand name, trade name for proton therapy is CyberKnife, because it sounds sexy, right? But it's just proton beam therapy. You're firing a concentrated beam of protons into the prostate and killing the DNA that way. And then radical prostatectomy, which is really the gold standard for treating prostate cancer. Because in a radical prostatectomy, the tissue is gone. You've removed it. When I started training, radical prostatectomies were primarily done open. We'd make an incision from umbilicus to pubic bone, lift the abdominal contents up, push them out of the way, get down into the pelvis, take the prostate out, take the seminal vesicles out, maybe do a pelvic lymph node dissection, and then sew the urethra back together with the bladder. Leave a drain. Okay. We talked a little bit about the concept of cytoreductive surgery when we were talking about renal cancer, that there is a role for cytoreductive nephrectomy. If somebody has metastatic renal cell carcinoma, you might still do a nephrectomy because some patients actually get better. They're Mets involute when you take out the primary tumor. That does not apply in prostate cancer. If they have metastatic disease, we're probably not going to do a radical prostatectomy unless they have really, really bad obstructive voiding symptoms from locally advanced prostate cancer. And even then, we're probably going to do something like a transurethral resection of the prostate and just open their urethra up for them so they can urinate. You provide no survival benefit by doing a radical prostatectomy in metastatic disease, so you're exposing the patient to all the risks of surgery for no benefit. So it has to be local disease, has to be confined to the prostate most of the time to do a radical prostatectomy. What you see in the upper right-hand corner, the way most radical prostatectomies are done now is robotically assisted with a Da Vinci robot. And to do that, you have to put the patient in stirrups and put them in extremely steep Trendelenburg. Point their head at the floor. You're literally duct taping them to the table so they don't slide off. I mean, it's medical tape, not duct tape, but you're taping them to the table so they don't slide off. And the robot gets parked between their legs. The reason you have to put them in steep Trendelenburg like this is to get the abdominal contents to move up towards the diaphragm so that you have room to work in the pelvis and get the prostate out. Okay? It's really slick. There's great videos on YouTube if you want to see what a robotic prostatectomy looks like from the inside. External beam radiation therapy, already spoke about. It's same end result as brachytherapy, except that the beam passes through other body structures to get there, so they can have symptoms in other organ systems like radiation proctitis, radiation cystitis. You can still see radiation cystitis in brachytherapy if the cloud of radiation gets up into the bladder, if the seeds are placed too close, but it's a much higher risk with external beam radiation therapy. And then androgen deprivation therapy is the only chemotherapy for prostate cancer that urologists will do. So we put patients on either a GnRH analog or an androgen receptor blocker to starve the prostate cancer of its fuel source, which is testosterone, right? Just like testosterone gets turned into DHT in normal prostate cells, abnormal prostate cells need testosterone also. So if you starve a patient of testosterone, then the cancer will stop growing. Sometimes it'll shrink. It doesn't cure them, but it can buy them time. Before they discovered medications to do androgen deprivation therapy, we would do simple orchiectomies. We would castrate patients to get rid of their testosterone production. Again, this is for metastatic disease. We're not talking about cancer that's still in the prostate. If they had metastatic disease, one of the things that we used to do, and sometimes patients still opt for that. There are patients that choose to have their testicles removed rather than have to come in and get a shot every 3 to 6 months. It's just not conducive for their lifestyle. Okay, brachytherapy I already talked about. This is how it's done. These are the seeds. This is how they're placed. Patients put lithotomy. They have a template that is put up against the perineum, and the treatment plan tells them which, you're playing battleship on a patient's perineum. The template tells them which hole to put the needle through and to what depth to deploy the seed. I mean, it's A12. You sunk my battleship. It's literally playing battleship. And you see that there's an ultrasound probe affixed to it. That's how you know that you're staying in the prostate and you're getting to the right spot, is with the ultrasound probe guiding the needle. Androgen deprivation therapy can cause all of these things. So when you do take away a male patient's testosterone entirely, they do have menopause type symptoms. Hot flashes, loss of libido, loss of muscle mass, truncal obesity, all of these things happen. And so you need to try to manage those things. Osteoporosis. Patients on androgen deprivation therapy should get DEXA scans. They should be on calcium supplementation, vitamin D, maybe a bisphosphonate. Okay. This is another nomogram to help you determine how a patient's gonna do. Likelihood of recurrence after prostatectomy. Not something that you're likely to use, but know that it exists in case you find yourself in a position to use it. And then, we've already talked about this, screening is controversial, right? The urology community believes that screening decreases morbidity and mortality. That's the bottom line. But the Preventive Health Task Force doesn't necessarily agree with that. Okay? You can read the bottom line there yourselves. Definitely increases detection, but does that benefit patients? The urology community says yes. If you follow them long enough, the ones that received screening have a survival benefit over the patients that don't get screened. Here's the USPSTF guidelines, okay? Now, I'll let you read that on your own. We've already talked about this. Complications, I'm not gonna have any questions for you about complications from treatment of prostate cancer, just know that those complications exist. The AUA has updated guidelines as of 2023. You can read those on your own if you like. I'm not gonna be tested on them. Very important, shared decision making. You shouldn't just order a PSA on somebody without telling them. Make sure that they know you're doing it and why you're doing it. The one thing I do expect you to know about the guidelines is when to start. That's the one thing I expect you to know. When to start. Average risk, 45 to 50 is the age range where you would start offering baseline PSA, okay? If they're high risk, it's 40. 40 is the youngest age, so your high risk population, African American, primary male relative. This is who you're gonna start screening at 40, okay? That's what I expect you to know about the updated guidelines from the AUA. Any questions about that? Okay. Again, you can read these yourselves. I don't expect you to know them. There's multiple validated risk calculators out there besides the PCPT one that I showed you earlier. Here's the NCCN guidelines. We talked about this before. You can look these up on your own. It's a great way to learn about all the different recommendations from all the different expert bodies out there. American Cancer Society still says 50 for beginning the discussion in average risk, 45 in high risk. AUA has taken that down. So the AUA guidelines are what I expect you to know. Again, more stuff that you can look at on your own time. PSA velocity, PSA density. All I expect you guys to know from a clinical practice standpoint is PSA. What is it? If I have them on a 5-alpha reductase inhibitor, what do I need to be thinking about? Questions? All right.